Good afternoon, everyone. This is a very timely topic, and there is a lot of debate on the subject. But I would be very surprised if we have a clean winner at the end of this debate. And if there is a clean winner, it's probably going to be Sagar. I desist any contest from the get-go. These are my conflicts, and beyond the conflicts are disclosure. So this is not a debate between Sagar and myself, because he'll likely win. But this is a debate that each of the clinicians actually have every day when we're treating patients, trying to decide what is the best treatment strategy for those relapsed myeloma patients. We have an embarrassment of riches, and what I'll try to do over the next few slides is trying to rationalize why monoclonal antibodies make more sense. And then Sagar will come on the stage and blow me away. So the holy grail of cancer medicine has been how to return a cancer patient to immunocompetence. So of the people sitting in this room, 1 in 3 will develop a malignancy in their lifetimes. And I'm simply stating the facts, ladies and gentlemen. But what usually happens in an immunocompetent host is our immune system is able to weed out those abnormal cancer cells that result from abnormal cell division, and the immune system develops competency and continues to weed those kind of cells out. But in some of us, in our lifetimes, that will not happen. That mechanism will fail, and the cancer cells will develop immune evasion and start growing. And what immunotherapy is trying to achieve is to deliver that normalcy back again. And the way the cancer cells do this, and Dr. Ken Anderson will be giving a very detailed talk tomorrow about the future of myeloma therapy and highlighting a lot of what I'm talking about on this slide. But once the cancer cells, according to Ken, once the cancer cell moves into the bone marrow, it's like a lawyer moving into your neighborhood. It's not good. So a lot of bad things happen. These cells the cancer cells are secreting a lot of cytokines, and inhibitory signals come into play that down-regulate the Tregs and the Bregs. There is downregulation of the MHC class I on the surface of cancer cells to prevent antigen presentation to the immune system, upregulation of the inhibitory surface ligands. So there are a lot of mechanisms in play which make potential utility of monoclonal antibodies in this situation ideal. The advantage of monoclonal antibodies is having a novel mechanism of action and having additive or synergistic effects with other anti-myeloma therapies without overlapping toxicities. They're generally very well tolerated and can be combined with different drug classes, as has been demonstrated in different clinical trials. They can also be ideal in eliminating minimal residual disease and can be used in many different settings. And they can be used to target not just the myeloma cell, but the microenvironment as well as the immune signals. Disadvantages are the infusion reactions can sometimes limit its use in some patients. We don't have any specific biomarkers that guide which patients are going to respond to monoclonal antibodies. And most monoclonal antibodies, the long-term survivors are only 4, 5, or 6 years out with treatment, so we don't know the long-term side effects of these. And the cost of production and delivery of these drugs, it's very expensive, and that still needs to be addressed. But the monoclonal antibodies can be utilized in many different ways, and different monoclonal antibodies work through different mechanisms. Now, the first 3 mechanisms, the antibody-dependent cellular cytotoxicity, complement-dependent cytotoxicity, and direct apoptosis through signaling pathways, is something that most of the monoclonal antibodies, can deliver on their own. But you can also harness the power of antibodies by loading them up with a toxic payload. And that can deliver concentrated amounts of anti-cancer drug inside the myeloma cell. So these antibodies can also rely on other mechanisms, but are also delivering this toxic payload to kill the cancer cell. The other interesting mechanism is the bispecific T-cell engager. So one arm of the antibody can latch onto the T cell, the other one can latch onto the cancer cell, depending on what kind of cell surface it recognizes, and brings them together and let the magic happen, as they say in Disney. So, there are a lot of different ways in which the monoclonal antibodies can be utilized. This is a very, slide that most people are familiar with. Originally the slide only had one curve from Shaji Kumar's original paper in 2012, highlighting that patients who are both PI and IMiD refractory have very poor overall survival. And I had looked at the population of patients in the United States that include carfilzomib and pomalidomide exposed patients, and published this a couple of years back, showing 8-month median overall survival for those patients. So we don't have a lot of options once patients start becoming PI and IMiD refractory. And so, again, monoclonal antibodies and the different ways in which they can be utilized, there's a lot of potential, in developing different drug classes. When we're seeing myeloma patients and trying to select relapsed refractory therapy for them, we're looking at patient-specific factors, disease-specific factors, and prior treatment, and trying to come up with a strategy for them based on all of these. So it's not a toss of a coin. We are trying to put some thoughts into these relapsed patients. So age, performance status, presence of renal insufficiency, poor marrow reserve, neuropathy because of previous therapy, other comorbidities, cardiac disease, and diabetes. These are important factors in picking what mechanisms of actions you can utilize in patients. And then, risk factors, including high-risk cytogenetics, play an important role. Rapidity of relapse, how quick is the relapse? Is it a slow biochemical relapse, or is the disease exploding? And does the patient have plasma cell leukemia, extramedullary disease at the time of that relapse? Because the kind of treatments you're going to pick depends on that kind of presentation. And then previous therapies rendered, what kind of depth of response patients got with previous lines of treatment, how deep was the remission, how long was the duration of remission, whether patients will be able to travel to get an IV drug versus an oral regimen may be easier for them. There are parts of the United States where the nearest cancer center is 100 miles away. And so, choosing certain kinds of treatments or regimens over others, sometimes that also dictates your choices. So in general, the treatment approach for our first relapse patients, we like them to participate in clinical trials. We have IMiD-based regimens that we can utilize for patients who had no prior IMiD exposure. So there are patients who have had a bortezomib-based regimen, Cybor-D or VD, or they had prior IMiD use with good response and durable progression-free survival. So patients had prior bortezomib refractoriness after having received Cybor-D or VD and are progressing. You would like to think about picking an IMiD-based regimen. Similarly, for a PI-based regimen, patients may have not received bortezomib or a PI in the past. Prior bortezomib use with good response and durability of progression-free survival, or they are LEN refractory or intolerant. In the United States, the LEN maintenance patients kind of fall in that category. And then proteasome inhibitors are preferentially used for translocation 414 because of the survival benefit we see with proteasome inhibition in that patient population. And we don't forget autologous stem cell transplant. It's probably the cheapest option on this slide. So patients who have had benefit from their initial autologous stem cell transplant would be eligible for a salvage stem cell transplant with or without maintenance in play. So this is a summary of the LEN-based therapies that are available for early relapse myeloma patients. We have 4 trials. You just went through a lunch symposium where a lot of discussions around these trials were held, so I'm not going to talk about each small nuance. But what I would like to highlight is the fact that if you start looking at the depth of response that you get with different 3-drug regimens, ixazomib, Revlimid, dexamethasone, and all-oral regimen, and ELO, Revlimid, dexamethasone, and compare those with KRD or DRD, for example, you get better bang for your buck for the triplets on the right side of this table than the left side. And the pace with which you get a response is also slower for IRD and ERD compared to KRD and DRD. So you have to keep that in mind as you're thinking about what regimen to pick for your patient when they're having a slow biochemical relapse or a rapid relapse. How quickly do you want to cytoreduce them and alleviate the issues with their quality of life rendered by disease? The proteasome inhibitor-based options, namely Panorama 1, or as I like to call Failure 1, Endeavor trial, and the Castor study. So, panobinostat was combined with bortezomib dexamethasone, and even though this was a positive trial, in general, the toxicity, the GI toxicity from panobinostat, makes this less than an ideal agent, and in my clinical practice, we don't use this a lot, especially with bortezomib and dexamethasone. It may find a life with carfilzomib combination, but the median progression-free survival that you get is nowhere near what has been reported for KD. And the Castor trial, the median progression-free survival has not been reached. And if you start looking at, again, depth of response, the daratumumab-based triplet has better depth of response. We're not supposed to be comparing these trials across the board because the patient populations were different. But as you're trying to use this registration material to manage patients, these data do become important. And can we choose treatment based on high-risk disease biology? So, if we look at the Aspire trial and the Pollux trial, what is evident is high-risk patients, they're defined by having deletion 17p, translocation 414 and 1416 here. They do improve progression-free survival when compared to the standard or the standard of care arm on those clinical trials, but they don't completely overcome the high-risk prognosis rendered by those cytogenetic abnormalities. The same is true for the daratumumab triplets. With Eloquent 2 and Tourmaline as well, what was seen was a similar pattern. There is improvement, but perhaps not complete abrogation. The caveat probably would be the Tourmaline study, in which the high-risk patients that included translocation 414 patients had a similar progression-free survival as did the standard risk patients. And there, I think Murray went into more details in the last session. If we start teasing down the patients, within the high-risk population, my inclination is that the most benefit was reaped by the translocation 414 patients. What about depth of response? So the daratumumab triplets were the first 2 randomized phase 3 trials that actually looked at MRD negativity prospectively and demonstrated that the 3-drug combinations actually outperform the 2-drug combination from a depth of response perspective as well. And it doesn't matter what depth of response you look at, from MRD 10 to the -4, -5, or -6, the data-based triplets were superior to the doublets that they were being compared with. If we start looking at high-risk cytogenetics, none of the high-risk patients in the doublet arms achieved MRD negativity, whereas there were high-risk patients who were achieving MRD negativity with the data-based triplets as well. The message from this particular slide is, if you're trying to get your patients into best depth of response, a good 3-drug combination trumps a good 2-drug combinations, no pun intended by the use of the word trump. If you look at the number of patients who are achieving MRD negativity with RD, these patients are doing well in terms of progression-free survival here. But the number is fourfolds higher with the 3-drug combination. So when you have that patient sitting in front of you and you want to give them the best chance of depth of response and PFS, a triplet combination is probably the best option. And the only information we have, with all the phase 3 trials in this setting about which combinations get you to MRD negativity. It's the data-based studies. So this is kind of my general approach. If I'm thinking about an IMiD-based regimen, if it's a fast or aggressive relapse, both DRD and KRD are good options, but I would be choosing KRD for patients who have translocation 414. If it's a slow biochemical relapse, ELO-RD would still be, it would be an option, and again, IGZA-RD probably preferential for translocation 414. PI-based regimens for a fast aggressive relapse, dara-VD would probably be my first choice, followed by KD in that setting. So this is a summary slide. One size does not fit all in long-term management of multiple myeloma patients, and we have to weigh in disease biology, disease burden, and host factors to decide the best treatment strategies. Monoclonal antibody triplets have demonstrable superior depth of response, including achieving MRD negativity compared to doublets, and that effect appears to be both in standard and high-risk patients. And then there are other phase 3s that are coming down the pike, which will make the next year's debate more interesting. Pomalidomide Velcade Dex versus Velcade Dex. This will probably be relevant to lenalidomide refractory patients. KD with or without daratumumab, as well as dara-Pomdex versus Pomdex. And with that, I'll be happy to pass on the baton to Dr. Lonial. Thank you.